Hello, welcome to the last topic for midterms, the disorders of thrombosis. Our outline for today, first we define the terms thrombosis versus embolism, and then babalikan natin yung mga key players to regulate your coagulation process, congenital and acquired disorders, and its laboratory assessment. Okay, balikan natin ang definition. Thrombosis is actually inappropriate, okay, or excessive formation of your fibrin clot that has a problem later on. Kapag naipon yan, it can eventually obstruct your blood vessels, inhibiting the blood flow. Okay? Other term is thrombophilia or hypercoagulability. This is a condition wherein a patient is has a predisposition to form clot, excessive clot or thrombosis. Okay? And then, meron tayong tinatawag na embolus naman. Itong embolus, ito yung thrombus or clot na nagta-travel away from its source. Okay? So, pwede yung mag-travel sa heart, causing your MI or heart attack. Pwedeng to travel sa lungs, causing your pulmonary embolism. Sa brain, pwede mag-cause yan ng stroke. So we have major factors in the formation of thrombosis depicted in this diagram called VIRCHOW'S triad. Sa VIRCHOW'S triad, we have three factors. Number 1, endothelial injury. 2, hypercoagulability, and lastly, your abnormal blood flow. Balikan natin si endothelial injury or simply known as blood vessel injury. Kung maalala nyo, no, yung ating lining epithelium sa blood vessel is also known as endothelium. So, kahit ito lang ang mangyari, no, meron lang tayong blood vessel injury, pwede na siya mag-form agad-agad ng thrombosis. Or, pwede rin siya mag-start ng another key factor that would lead to thrombosis. So, first, no, ang blood vessel injury can actually disturb the blood flow. No? So, ito magiging consequence niya. And after that, kapag nagkaroon ng disturbance sa blood flow, hindi unilateral ang flow, nagkakaroon ng backflow, forming your thrombosis. And another consequence of your blood vessel injury is hypercoagulability. Kapag kasi meron tayong injury sa blood vessel, so meron tayong ongoing na coagulation process, and sometimes nagkakaroon ng overreaction, forming tremendous amount of blood clots. So ito yung tinatawag na process na hypercoagulability. And this can alone cause your thrombosis. Okay, tapos na tayo sa substitution test, no? Iwan na natin yung mga secondary hemostasis natin. Let's proceed with your fibrinolysis and thrombosis. So we have regulatory mechanisms to balance the coagulation factors and the anticoagulation proteins. So unahin natin itong mga natural anticoagulants natin. Okay, number 1, your TFPI or tissue factor pathway inhibitor or tinatawag nating CUNITs. Okay? So we have two types. CUNITs 1 inhibits your 7 and tissue factor complex. Your CUNITs 2 inhibits your factor 10. APC naman or the activated protein C. Si protein C inhibits your 5 and 8. Antithrombin naman or ET or in other books, antithrombin 3. It inhibits not only your thrombin but also your 9 10, and all of the contact group. Ano yung mga contact group? 11, 12, and prekallikrein and HMWK. ZPI naman, Z-dependent protease inhibitor, inhibits your 10 and 11. Protein S naman, it is not a solo protein. It needs a partner. So, kapartner niya si APC and TFPI. Heparin cofactor 2 naman, solely inhibits your thrombin. And then, thrombomodulin naman, it modulates the binding of your thrombin to activate the protein C. So, maraming kapartner si APC, thrombomodulin, and your protein S. So, the prevalence of thrombosis depends on the type or the classification. Kapag venous thrombosis ang pinag-uusapan natin, ang pathogenesis nito ay yung thrombosis malamang nanggagaling din sa lower half of the extremities or yung legs. So, ang tawag doon sa predisposition na yon is deep vein thrombosis. And kung mapapansin nyo, no, itong mga parts of the veins, iliac veins, popliteal veins, and femoral veins. Ang iliac vein and femoral veins, nasa ano yan? Hip area, no? Ang popliteal naman, nasa likuran ng inyong tuhod, yung ano na yon, yung region na yon, yun yung mga popliteal veins natin. And kung ma-observe nyo, di ba, meron tayong may ma-observe na mga varicose veins, and it is one of the sign na baka meron kang DVT or deep vein thrombosis. And another classification for thrombosis is arterial thrombosis, which is a major cause of your heart attack and strokes. Ang composition ng mga to ay nung thrombus ng arterial thrombosis ay meron siyang fats, platelets, no? Even meron din mga calcium deposits. And ang litaw ng combination ng mga yon is what we call white thrombi. So yung white thrombi, yan yung na-observe sa mga atherosclerotic veins natin or atherosclerotic blood vessels. Sa presentation naman, no, it will depend on what type of disorder. Kung congenital disorder ba yan or acquired disorder. Pero the major difference between the two, no, congenital starts at much younger age than your acquired cause of disorders. So, balikan natin yung mga congenital cause of thrombosis. So, yun nga, no, madalas mga young adults or even younger sa mga bata. And kung papansin mo, napaka-unusual ng mga sites ng thrombosis. Meron sa mesentery. Mesentery are your blood vessels in the gastrointestinal tract, renal sa kidneys, and axillary sa kilikili. So, very unusual yung mga site ng mga thrombosis. So, dapat kapag may ganyan ka ng findings, mag-suspect ka na baka may congenital, no? Or may genetic predisposition yung pasyente. Next criteria is recurrent yung thrombosis. Even naggagamot na yung pasyente, no? Paulit-ulit yung episodes ng thrombosis attack. So, doon pa lang baka merong problem sa genes ng pasyente. And lastly, dapat may family history, no? Kailangan detailed talaga yung interview mo with the patient. Kasi hindi lang dapat mo gagamutin yung sakit. Kailangan malaman mo saan nanggaling yung sakit. Okay? Dito tayo sa acquired causes of thrombosis, no? Older age are much more predisposed to acquired cause of thrombosis, no? Ang mga matatanda, no, mas predisposed sa thrombosis rather than bleeding tendency. Next, smoking. Bakit kaya? Kasi ang components of cigarette are one of the major cause of endothelial injury na na-discuss nga natin kanina na major factor in the thrombosis formation. Next, medications such as OCP. Ano ibig sabihin ng OCP? Oral contraceptive pills, no? Na tinitake ng mga babae during contraception or other diseases such as may hormonal imbalances. So, anong problema with OCP? May isang category ng OCP na tinatawag nating estrogen only OCP. And estrogen daw is one of many hormones na nagko-cause ng hypercoagulability. Okay? Kaya hindi lahat ng babae ay pwede sa OCP. Kailangan mag-i-investigate si OB-GYN. Nagsusmoke ba ang pasyente? Kung nagsusmoke ba, hindi na siya pwede mag-OCP. Okay? Meron bang mga varicosity ang pasyente sa legs? Hindi na siya pwedeng mag-OCP dahil alam mo na may hypercoagulability tendency ang pasyente. Next naman, pregnancy. So, di ba sa pregnancy meron tayong hormonal imbalances? Minsan mataas ang progesterone, minsan mataas ang estrogen, and this altogether can cause hypercoagulability. Surgery and chronic disorders can predispose your patients to thrombosis dahil unang-una, di ba kapag meron kang chronic disorder or nag-undergo ka ng surgery, very bedridden ka, no? Hindi ka gumagalaw. Kapag ganyan kasi, no, nagkakaroon kayo ng stasis of your blood flow. Di ba nga, discuss sa VIRCHOW'S TRIAD, one of the major factor is the abnormal blood flow. Okay, sa risk factors naman tayo. In congenital cause of thrombosis, no, if meron kang mga ganitong mga genetic disorder, pwede kang magkakaroon ng predisposition sa thrombosis, such as, di-discuss naman natin to later on, antithrombin deficiency or AT deficiency, protein C deficiency, free protein S deficiency, APC, ano APC? Activated Protein C Resistance or Factor V laden mutation. And ito yung mga least common. Prothrombin G 20210A and hyperfibrinogenemia. Next naman, yung i-discuss natin mamaya, yung APAS. Ano nga ba ulit ang APAS? Anti-phospholipid antibody syndrome. Mga malignancies or cancers, no? Bakit anong type of cancer ang mas mataas ang chance na magkaroon ka ng blood clot disorder? And lastly, yung mga blood disorders natin. Naalala niyo yung mga myeloproliferative disorders. These are your CML, essential thrombocythemia, primary myelofibrosis, and polycythemia vera. Meron din tayong type of leukemia na merong hypercoagulability tendency such as your acute promyelocytic leukemia or M3 type of leukemia. And PNH. Ano yung PNH? Paroxysmal nocturnal hemoglobinuria. So, our first topic is antithrombin deficiency. As a recall, ang antithrombin inhibits your thrombin from the name itself. And in addition to that, no, not only thrombin, it also inhibits your factor 9A, factor 10A, and contact group. Bakit may A? Ibig sabihin, activated factor 9, activated 10, factor 10. Okay? Ang AT deficiency is generally congenital, no, but can be acquired in what events or condition. So first, discuss natin yung liver disease. Liver disease, bakit siya involved sa AT deficiency? Because antithrombin is a protein, no? So basically lahat ng proteins, 'di ba, na produce sa liver. So kapag sira ang liver, walang napoproduce na antithrombin. Second condition is nephrotic syndrome. Kailangan nephrotic kasi in nephrotic syndrome lang merong proteinuria. Lumalabas lahat ng proteins mo sa urine. Sa nephritic syndrome, walang proteinuria. So, tandaan nyo yan back in your AUBF, no? Yung difference between your nephritic and nephrotic. Next, your prolonged heparin therapy. Dito naman, meron tayong overusage of your antithrombin. Kasi ang heparin, ina-activate niya yung antithrombin para gumalaw or maging active. Kung madami kang heparin, madami kang nagagamit na or na-activate na antithrombin, nauubos din sila. Okay? And lastly, your DIC na implicated with increased circulating thrombin. Pag mataas ang levels mo ng thrombin sa katawan, yung antithrombin ngayon gagalaw to inhibit your thrombin. No? Mas madaming thrombin, mas madami kang nagagamit na antithrombin, nauubos yung AT levels mo. Okay, classification naman tayo. There are two types, no? Simple lang, type 1, type 2. Pero ano ang difference ng dalawa? Ang type 1, quantitative. Ibig sabihin, yung number or the levels of your AT ang may problema. Sa type 2 naman, normal naman yung levels mo ng AT. Pero, walang silbi or non-functional. Hindi naman pwedeng gamitin. Okay. And then, for assessment, pwede kang gumamit ng AT activity assay, which can be used for both type 1 and type 2. Parang screening lang, no? Kung mataas ang suspicion mo for AT deficiency, pwede mong gamitin to. And kung curious ka, you can differentiate the type 1 and type 2 using AT antigen level. I-discuss natin to sa next few slides. Okay, dito muna tayo sa AT activity assay. Sabi nga natin, no, ito ay hindi specific. Pwede tayo maka-diagnose ng type 1 and type 2 AT deficiency. So, ano ba nangyayari in AT activity assay? So, first, gagamit tayo nga ng reagents such as yung heparin and yung excess factor 10A. Diba, kanina sinasabi natin na it can bind not only to thrombin but also to factors 9A, 10A, and contact group. And meron tayong substrate na ang end color is yellow product. So, tingnan natin yung whole process muna. Okay, meron kang 80 sa katawan, right? Tapos, ang ilalagay mo is first ang heparin to bind with antithrombin. Okay? And then, maglalagay ka na ng next reagent which is your factor 10A para mag-bind din ulit kay antithrombin. Creating this complex, your AT, heparin, and factor 10A. And then, yung mga hindi nakapag-bind the factor 10A, ay may mga excess yan, no? Hindi naman lahat makakabag-bind sa AT levels ng pasyente. Ito yung magbabind sa substrate or dun sa yellow reagent. And sabi natin, the more intense yung color ng final product, lesser yung levels ng AT. Okay? The lesser the yellow intensity, more ang AT. Okay? Yun lang naman ang papamemorize ko sa inyo, no? How to interpret. Hindi naman yung first step hanggang sa last step. So, tingnan natin naman kung walang AT at all ang pasyente. So, kung walang mababind ng heparin, no? Libre lahat ang mga factor 10A. The more factor 10A na makakapag-bind kay yellow substrate, the more intensity ng color. Thus, yun nga, more yellow product means less AT levels. Kung na-appreciate niyan. Pero, syempre, practical lang tayo. Aralin nyo na lang yung paano mag-interpret. Okay, next test is AT antigen levels, which can differentiate your type 1 and type 2. Dito naman, spectrophotometry tayo, no? It will measure the wavelength of light emission. Okay? So, ang sabi daw nila is that light emission is directly proportional. Unlike yung kanina, di ba? Inversely proportional do sa AT activity test. Dito sa AT antigen levels, directly proportional. The more light, more levels of AT. The lesser light, lesser AT levels. Okay, balikan natin type 1 again. Kapag type 1, deficiency in levels. Type 2, okay ang levels mo pero non-functional. So, sino dito ang may normal result? Si type 2. Ang type 1, dahil less ang AT levels, less din ang light emission. Dito tayo kay Activated Protein C Problems or APC. APC, recall natin, no? Babalikan din naman natin yan mamaya. APC inhibits your 5A and factor 8A. Katulong niya yung cofactors protein S and activator thrombin thrombomodulin. The problems you encounter with APC are, number 1, protein C deficiency. Levels ang problema mo dito. Then, APC resistance or factor 5 laden mutation. Ang problem mo naman is yung receptor, no? Tama lang yung levels mo ng APC, pero yung receptor mo, yung tatanggap dun sa protein C, wala or may defect. And then APC resistance is also known as factor 5 laden mutation. Dito, normally, glutamine ang meron sa mga activated protein C amino acid. Pero napapalitan yung glutamine content nito ng arginine. And this is the problem. Ito kasing arginine would resist the levels or yung action ng activated protein C. So, hindi siya makakapag-inhibit ng mga kailangan niyang i-inhibit. Okay? And then, for the assessment, first, for the screening test lang muna, APC resistance clot-based assay, and for confirmatory, factor 5 latent mutation assay. Dito tayo sa clot-based assay muna. Ang reagents na pwede natin gamitin, yung pang PTT reagent or the partial thromboplastin time reagent, factor 5 depleted plasma, and calcium chloride. The result would usually, in a normal patient, more than 1:8 ratio. Okay? Kapag may APCR, less than 1:8 ratio of normal to patient na clot-based assay time. So, discuss natin yung process kung paano ginagawa itong clot-based assay. So, let's proceed with the processes involved in APCR clot-based protein. So, first, combine natin yung PTT reagent and factor 5 depleted plasma plus your patient plasma. And then, you will prepare 2 test tubes. Test tube 1, mag-add ka lang ng calcium chloride. Sa test tube 2, mag-add ka ng calcium chloride plus APC. Pero anong principle ng dalawang test tube na to? Okay? Doon tayo sa test tube 1. Diba, ang nilagay lang natin is calcium chloride. Sa normal patient, no, there will be a coagulation kasi inactivate ni calcium chloride. And eventually, may inhibit ng APC na laman ng patient plasma. Okay? So, tawag dito, nagkakaroon ng normal PTT results which is 27 seconds or less. Dito naman tayo, normal na patient. Sa test tube 2, mag-a-add tayo ng calcium chloride and APC. Ibig sabihin sa test tube 2, more APC means more inhibition of coagulation. Thus, prolong ang time ng PTT up to more than 49 seconds. Okay, ano ang difference naman ng abnormal na patient or may mutation na patient? Natin. So, M is yung mutation. Kapag sa test tube 1, no, may mutation ng APC or meron kang resistance against APC, there will be coagulation and cannot be inhibited by the APC levels inside the patient plasma. And then, ang litaw mo dyan, ang PTT mo is still 27 seconds kasi merong coagulation. Kapag sa test tube 2 naman, due to resistance, there is still no inhibition. Okay? So, mangyayari pa rin, magkakaroon ka pa rin ng clotting process at coagulation. Thus, your PTT is less than 49 seconds. Okay? Pero, doktora, sobrang haba nung explanation ng process, di ba? Tatandaan lang natin at the end of the day, paano mag-i-interpret ng ratio. Okay? Sabi nga natin, no, ang normal na pasyente would show a more than 1:8 ratio of the two test tubes. Okay? Ang APCR less than 1:8 ratio ng dalawang test tube. Ito lang naman ang importante. Next, your deficiencies of protein C and protein S can be congenital or acquired. Kapag congenital, nakikita sila in neonatal purpura fulminans. Ibig sabihin, pagkalabas pa lang ni baby, prone na siya into formation of your purpura. And madalas, fulminant. Ibig sabihin, makikita mo sila from head to toe. Acquired cause naman is prolonged warfarin therapy. Okay, tatandaan natin kanina, prolonged heparin therapy, anong deficiency? Your antithrombin. Ang prolonged warfarin therapy, protein C and protein S deficiency. Dahil protein C and protein S are vitamin K dependent. Si warfarin, galit siya kay vitamin K. Kapag na-inhibit niya to, wala ng production of your protein C and protein S. So, ito yung itsura ng neonatal purpura fulminans. Okay? Sabi nga natin, no, mga newborns ang may high risk dito, and ang purpura can be seen from head to toe. Dito, madalas, magsususpect ka na baka mayroong deficiencies of protein C and protein S. Okay, next, laboratory assessment, no? Magkaiba sila, no? Tingnan natin yung protein C muna. Protein C assessment is done using PROTAC reagent. PROTAC reagent contains agkistrodon contortrix venum. So, memorize yan usually. Okay? And ang result, pag ang pasyente ay may deficiency in protein C, no or lesser ang intensity of the yellow product. Merong tayong substrate na ginagamit in PROTAC. And ang end color niya is yellow. Kapag in this assay, directly proportional tayo dito. Okay? Pag no and lesser yellow intensity means lesser levels of your protein C. Sa protein S naman, ang ginagamit na reagent is activated protein C plus Russell Viper venom. Kasi ang protein C, kung maalala nyo back in midterms, ginagamit siya or cofactor siya ni protein C. So it cannot do its own work without its partner na cofactor. And kapag ang result naman, clotting time ang check. No? Shorten clotting time kapag may protein S deficiency ka. Meron tayong mga false positives. Okay? Take note lang natin no, na kapag may presence of lupus anticoagulant which reacts to any reagent containing snake venom. Ito mga to, snakes kasi itong mga to. Okay? And then, next, yung use of anticoagulant drugs such as your argatroban and dabigatran, which we will discuss this type of drugs later on. Take note muna natin sa ngayon. So, huwag tayong kalimutan na protein C agrees Trodon contortrix, ang protein S Russell Viper venom plus APC. Next condition, homocystinemia. It's a genetic defect, no, in the metabolism of your methionine. Kapag may homocystinemia ka, ibig sabihin high levels ng homocysteine sa katawan. And then next, kapag mataas ang levels ng homocysteine, mataas din ang mga levels ng mga products nito such as your vitamin B complex which are your B6, B9, and B12. So, ano ang other name ni B6? Your pyridoxine, B9, your folic acid, and B12, your cobalamin. And in this condition, prone ang mga young adults to brain infarct or stroke. So, tinatawag natin stroke in the young adults. There is no established association between homocystinemia and thrombus formation. No? Ang theory pa rin dyan ng mga scientists is that meron daw damage to endothelium due to increased levels of your homocysteine. Okay, so aside from inherited problems in fibrinolysis, so meron tayong tinatawag na acquired coagulation inhibitors. No? Hindi ito naturally occurring, okay? Bigla na lang ito na-form, idiopathic, kumbaga, okay? And it involves your formation of autoantibodies. Ano ulit ang autoantibodies? Antibodies against the self-antigen. Okay? And a type of autoantibodies that has a role in inhibition of your coagulation is in IgG4 type of antibody. The most common type of acquired anticoagulants are your autoanti-factor 8, which is also known as acquired hemophilia. Okay? And meron tayong mga tests to identify or to screen for acquired coagulation inhibitors. As a screening, pwede tayong mag-mixing studies. Sa mixing studies, i-discuss natin yan later on. Pero the expected result, kapag meron kang autoanti-A, no, prolong ang PTT, not corrected in normal plasma. Okay? Sa Bethesda assay naman, this is a more confirmatory test. Kapag na-identify mo sa mixing studies mo na itong result na to, compatible with autoanti-A antibodies, kailangan mo rin sila i-quantify. No? Kailangan mo bilangin kung ilan yung antibodies mo na yon through this test, yung Bethesda assay, which is a quantitative assay. So, sa HIT or recently named as HITT, which stands for Heparin-induced Thrombocytopenia with Thrombosis, nagkakaroon ng two processes na delikado, lalo sa mga patient with prolonged heparin therapy. Bagsak ang platelets, pero blood clot former ka. So, paano nangyari to? Okay? Bagsak ang platelets mo dahil sinisira ni heparin ang platelet factor 4 which stabilizes sana the platelets. So, kapag sira ang platelet factor 4, mababa or maikli ang lifespan ng platelets, madaling ma-destroy. Okay? Sa thrombosis naman, nagkakaroon ng heparin resistance. Okay? Ano bang ginagawa ng heparin? It usually activates your antithrombin to inhibit your thrombin. Thus, walang formation sana ng blood clot. Pero kung may heparin resistance ka, no, walang ganitong formation. Okay? Walang inhibition of blood clot formation. Pag-usapan naman natin yung mga types of heparin which is will be discussed later on, no? Pahapyaw lang. So there are 3 types of heparin. First, your UFH or unfractionated heparin, LMWH or low molecular weight heparin, and lastly, the synthetic one or man-made is fondaparinux. So, ang difference niyan iba is the size. Lahat large except your low molecular weight heparin which is the smallest. Lahat pwedeng mag-cause ng HIT except your fondaparinux. Lahat pwede mong i-monitor or kailangan i-monitor due to its side effects except your low molecular weight heparin and fondaparinux. No need for monitoring. In case of overdosage naman, no, lahat prone mag-overdose sa heparin except sa fondaparinux. Kapag naman naka-overdose ka ng heparin, losing of these two, ang gagamitin mong antidote is protamine sulfate. Okay? Next, assessment. We can screen for heparin-induced thrombocytopenia first, syempre by platelet count and function tests such as your aggregometry. Okay? And for confirmatory and reference method, lagi yung mga fancy ang pangalan, no? Yung serotonin release assay. It's nice to know. Nasa book kasi, nasa Rodax. Okay, next naman, anti-phospholipid antibody syndrome or APAS. This is not the final diagnosis. Actually, ang APAS, kasama yan ng other condition. No? It is a secondary to another autoimmune. Madalas autoimmune disorder siya. Okay? So, anong mga antibodies ang kasama sa APAS? Number 1, your lupus anticoagulant, which is the most dangerous type of antibody, no? Kasi it has an effect to our coagulation process. Next, your anticardiolipin antibodies, which cross-react with your BDRL testing. Diba sa BDRL, you make use of your cardiolipin as reagent. And lastly, your beta-2 glycoprotein 1 antibodies. So, we have 3 major antibodies. Hindi lang ito, pero ito yung tatlong pinakamaraming antibodies present in your APAS. Ay, sabi nga natin, di ba, secondary to another disease siya. So, you have to suspect if number 1, meron ang APAS, you have to suspect kung na may APAS ang pasyente if number 1, meron siyang unexplained thrombosis. No? Thrombus former siya kahit wala namang mga damage or hindi siya nag-undergo ng mga surgery or damage to any blood vessels and still madami siyang blood clot, mag-suspect ka ng APAS. Next, thrombocytopenia. Thrombus former ka, pero yung platelets mo bagsak naman. Okay? So, magtataka ka, baka may mga extra protein siya na nakakapag-form ng thrombus. And lastly, kapag babae naman, no, ang manifestation dyan, meron silang recurrent fetal loss. Paulit-ulit na merong abortion sa pasyente. Dahil ang akala dito sa syndrome na to, no, ang akala niya abnormal protein ang bata, ang fetus, so magpuproduce siya ng mga antibodies against dun sa forming fetus. So magkakaroon ng recurrent or paulit-ulit na fetal loss. So sa mga assessment naman, you can use substitution studies, no? You rule out muna any clotting factor deficiency. And then mixing studies, aaralin natin yan mamaya, and parallel assays. Na-discuss natin later on. Okay. Dito tayo sa substitution studies. In APAS, normally, or ang expected result mo is that dapat walang correction for all prepared reagents such as your aged serum, fresh serum, aged plasma, fresh plasma, and adsorbed plasma. Diba, itong mga to, ginagamit sila kapag may clotting deficiency. Pero in APAS, wala ka naman talagang clotting deficiency. Kaya, not corrected kahit maglagay ka ng pang-correct na reagent. Prolong pa rin yung iyong clotting time. Okay. Dahil may connection to sa ating coagulation process, dito tayo magpo-focus sa ating lupus anticoagulant. Okay. Ano ang pinaka-mainam na gamitin natin as a method to test for lupus anticoagulant? So, pwede tayo mag-substitution testing. No? In APAS, not corrected for all prepared agents. No? Age serum, fresh serum, H plasma, fresh plasma, adsorbed plasma, okay? Lahat na yan affected or not corrected. Okay? Kasi lahat ng clotting factors ini-inhibit niya. Iwan ko muna yung substitution studies, no? Di ba na-discuss naman natin yan back in midterm. Proceed tayo with mixing studies naman. And of course, i-discuss natin ulit yan in SEM 2, part 2 ng HIMA. No, di-discuss natin yan lahat. Babalikan natin yan lahat. Mixing studies naman tayo. So, anong ginagawa in mixing studies? Sobrang haba na itong process. Mas maganda kasi i-discuss natin para mag-gets nyo rin kung bakit ganito yung interpretation ng result. Okay? In PTT, partial thromboplastin time, if prolonged, okay, you can proceed to mixing studies. So sa first muna tayo, okay? Kapag PTT ay prolonged, you can proceed with thrombin time. Okay? Kapag ang thrombin time mo ulit ay prolonged, maglagay ka ng extra reagents such as your Hepzyme. Hepzyme means ang tawag dito, it will bind to heparin present in the patient plasma. Okay? Kasi ang heparin can prolong both PTT and your thrombin time. So, i-rule out mo, baka naman may heparin, madami siyang heparin or may prolonged heparin therapy. So, gamit kang Hepzyme. So, i-repeat mo ulit ang PTT mo. Kapag nag-normal, ibig sabihin, ang may kasalanan nga doon sa bleeding condition is heparin. So, heparin overdose ang final diagnosis mo. Okay? Pwede kang mag-assay for heparin, pero still, maganda na tong parameter to diagnose heparin overdose. Okay? Kapag naman, yung thrombin time mo is normal, okay? Pwede ka mag-proceed to another test. You mix, ang tawag dito, plasma with normal plasma. yung patient plasma mo, i-mix mo with normal plasma, and then kapag ang result is uncorrected, hindi na correct ng normal plasma, ibig sabihin, mataas ang chance na meron siyang lupus anticoagulant, which is one of the antibodies of your APAS. So, kapag APAS, PTT is prolonged, thrombin time is normal, pero kapag na-mix na siya with normal patient plasma, uncorrected pa rin ang PTT or prolonged pa rin ang PTT. Okay? APAS yan. Next, if in case nag-mix ka ng normal plasma, na-correct siya, okay, you proceed to next test. You mix a patient plasma and normal plasma and you will incubate it at 37 degrees Celsius for 1 to 2 hours. Repeat PTT ka kapag corrected na or normal na yung PTT, baka clotting factor deficiency. Okay? Next, kapag uncorrected pa rin yung PTT mo, baka merong specific factor inhibitor or anticoagulant or naka-anticoagulant therapy siya. Okay? Masyadong mahabang process, 'di ba? Medyo nakakawindang, pero still sa mga ganitong assessment, you have to memorize only the test results. Okay? Paano mag-interpret? Again, balikan natin, no? Kapag may heparin overdose, ang thrombin time is prolonged and corrected by using your Hepzyme. Ang lupus anticoagulant can be diagnosed kapag ang PTT mo is prolonged. PTT is not corrected after mixing of normal plasma. Okay? Clotting factor naman, PTT is prolonged. PTT is corrected after incubation with normal plasma. Okay? Anticoagulant excess naman, kapag nag-undergo ka na anticoagulant therapy, PTT is prolonged. PTT is not corrected after incubation with normal plasma. Take note natin, baka magkalituhan with lupus anticoagulant. Dito, walang incubation. Ma-appreciate mo na yung prolonged PTT. Dito, kailangan pa ng incubation para ma-appreciate mo yung expected result. Okay? Next, your parallel assays. First, ano ba ibig sabihin ng parallel assay? Ibig sabihin, ito yung type of testing na gumagamit ng more than one or concurrently, sabay-sabay na test ito. You will use more than one test in parallel to each other. So, ano yung mga sub-tests under parallel assay? So, pwedeng diluted thromboplastin time or DTT, diluted Russell-Viper venom time or DRVVT, Cowlin's clotting time, KCT, and simply your PTT. Okay? So, anong difference naman ng mga to? Bakit kailangan silang gawin concurrently? Okay? Or in parallel to each other? Ang DTT can activate your factor 7, which is a member of extrinsic pathway. DRVVT, doon naman siya sa common pathway. It activates your factor 10. KCT and PTT can both activate your factor 12. So, anong itsura ng parallel assay? Anong mga processes dyan? Again, your DTT can activate your extrinsic factor through factor 7, DRVVT sa common pathway sa factor 10A, and KCT and PTT sa 11. 12, factor 12A. Sa contact group in intrinsic pathway. So, lahat ng yan can proceed to the normal coagulation process. So, paano ito nakaka-diagnose ng APAS? Diba, ang Parehas kasi yung APAS sa mga problems with clotting factors. Okay? If ever normal ang result na itong parallel assay natin, ibig sabihin wala tayong problema with our clotting factors. Instead, meron tayong problema with regards to the autoantibodies. Pwedeng baka lupus anticoagulant. Okay, malignancies naman, ang pathophysiology behind the thrombus formation is that tumor production of tissue factor. Okay, kaya prone silang mag-pulmonary embolism, mga yan, stroke or heart attack. Pero more commonly, pulmonary embolism. Trousseau syndrome is actually a syndrome of thrombosis, which is specifically found sa mga may cancer sa pancreas and colon and other parts of your gastrointestinal tract. Okay. So, ito yung mga yan, no? Okay. So, anong mechanism behind thrombosis in this type of condition? Ang theory is there is an established increased platelet number and activity. Very sensitive ang mga platelets, nagdidikit-dikit sila, no? Nag-adhere to each other, causing or producing blood clots. And then we have to take note as well another type of leukemia na may mataas sa predisposition to thrombus, yung M3 leukemia. Ano ibig sabihin ng M3 ulit? Your APML. APML stands for acute promyelocytic leukemia. And i-recall lang natin, no, sa M3 din, merong DIC lagi, no, or Disseminated Intravascular Coagulopathy. So, bleeder din sila as well. And then, yung makikita natin under microscope, your phagot cells with our rods. Okay, next blood disorder is your paroxysmal nocturnal hemoglobinuria. Recall lang natin, ano meron ba sa PNH? There is a mutation called PIGA or PIGA mutation. Ang nangyayari with this type of mutation, it will cause deficiencies of your DAF protein or decay accelerating factor, which is found in the CD55. And your MRRL protein, which stands for membrane inhibitor of reactive lysis, which is found in CD59. Ang theory behind thrombus formation in PNH is that due to its mutation, no, there is a high platelet hyperactivation. Very normal ang counts pero very active, and then therefore there is excessive levels of your blood clots. Okay, DIC naman tayo. Disseminated intravascular coagulopathy is also known as defibrination syndrome or consumption coagulopathy. Defibrination syndrome kasi madaling mag-lyse, no, ng fibrin clot or the fibrin stable fibrin. Madaling matunaw, no? And then consumption coagulopathy, nauubos yung clotting factor mo dahil madami or disseminated yung blood vessel damage. And DIC is not the final diagnosis. Then, no, it is secondary to another problem. It is most commonly implicated in number 1, hemorrhagic viral syndrome such as your dengue. Ang isa sa mga kinakamatay ng mga dengue patient is DIC. Next, your gram-negative bacterial infection. Ano ba yung mga gram-negative natin? Yung mga E. coli, mga yan. Pregnancy, mga pregnant women, prone din magka-DIC. And lastly, your microangiopathic hemolytic anemia such as your TTP or thrombotic thrombocytopenic purpura and HUS or your hemolytic uremic syndrome. So, ito yung mga yan. Okay. Okay, for assessment, no? Kung matatandaan natin kanina, it affects your platelet count. So, low yan. No? PBS. PBS shows the presence of your schistocytes or the helmet cells. Okay? Prolong sa lahat ng test. Your bleeding time is prolonged kasi uubusin niya ang platelet mo, sisirain niya yung mga blood vessels mo. Prolong lahat din itong mga clotting studies kasi uubusin niya yung clotting factors. Pero as a confirmatory test, you can use your D-dimer levels. Because D-dimer levels is a product of your fibrin degradation of your plasmin, right? Kung natatandaan nyo kanina sa discussion. Okay. Again, no, the D-dimer serves as a marker that the whole process of coagulation plus fibrinolysis has occurred. Kapag maraming ganyan, problematic nga. Okay? Because these FDPs inhibits your hemostasis, platelet activation, and the stabilization of your fibrin. It is a marker for thrombosis, no? As anong other term? Clot former. And again, ulit to, no? The testing of your D-dimer is a confirmatory test, no? For your DIC, your Disseminated Intravascular Coagulopathy. Coagulopathy to, okay? And it is also a test to rule out your venous thromboembolism. Ano nga ulit yung thromboembolism na to? Kapag nag-travel yung clot mo all throughout your body. Okay? I-rule out mo yung possibility na nag-e-embolus ka, no? Using your D-dimer. Okay. Pag sinabi natin fibrin degradation products, we assume na natapos na yung coagulation process. So that's why meron tayong ine-expect na stable fibrin clot. Okay? And then, i-assume din natin kung present ito, may nag-act na plasmin. So, meron ding ongoing na fibrinolysis. So, the presence of these products, may dalawa na tayong assumption. Natapos na yung coagulation and may ongoing na fibrinolysis process. Okay? And these products are actually a bad sign or a warning sign. Okay? Bakit kaya? Pag dumadami itong FDP sa katawan mo, ibig sabihin ongoing ang bleeding, ongoing ang coagulation, ongoing ang fibrinolysis. So kapag madami to, madami rin ang damage dun sa ating system. Okay? And aside from that, itong mga FDP, delikado rin siya sa system natin because number one, it inhibits your hemostasis. Okay? Kasi nga ongoing itong mga process na to, nauubos yan, no? Nauubos yung platelets, yung clotting factors. Therefore, hindi nakakapag-start ng maayos yung hemostasis natin. Aside from that, FDP prevents the platelet activation, no? It prevents the secretion of the granules. And lastly, it hinders the fibrin polymerization o tinatawag natin the formation of your fibrin clot. Okay? So, bad news itong mga FDP na to. Okay, balikan natin yung fibrinolysis process. So, di ba ang plasmin, it acts to digest both fibrinogen and the fibrin. Okay? Punta tayo sa fibrinogen. Paano niya na-degrade? So, fibrinogen has a D-dimer and a E-monomer. Okay? So, i-degrade yan ng plasmin, magkakaroon ng Fradmin X. Okay? It has D-dimer and an E-monomer. Okay? And then, malidegrade pa further ng plasmin into fragment Y. So, meron D E dimer plus a D monomer. And then, madidegrade ulit ni plasmine into fragments D and E. So, hiwa-hiwalay na yan. So, ganito ang fragmentation ng plasmine ng fibrinogen. Punta naman tayo sa fibrin. Okay, sa fibrin, di ba, ito ang mas stable or mas activated form of your fibrinogen. So, mas maraming mga dimers of your D and E monomers. So, pag binibreak yan ng plasmine, no, magkakaroon ng YY and DXD complex. Ano yung YY na yan? Ang Y is composed of a D and E. Diba? Remember ito, no? Fragment Y has a D and E. So, ito yung isang Y at ito yung isang Y. So, YY complex yan. Ano naman yung DXD? Ang DXD ay, ang ibig sabihin niyan, meron tayong dalawang D-dimer with an E monomer. Ano ba yung X ulit? It has a D-dimer with an E. So, ito yung X. Nagigets nyo, no? Ito yung X part. Ito yung D. At ito yung D. So, dito na-derive yung name niya. So, DXD complex. So, further, madidegrade yan ulit ng plasmine into this dead complex E and D dimer. So, magko-combine ito, DED, an E monomer, and the D dimer. So, ito yung focus ngayon ng D-dimer testing. Okay? Saan ginagamit ang D-dimer testing? Ginagamit yan lalong na in conditions called DIC or Disseminated Intravascular Coagulopathy. Okay, in summary, nilagay ko lang siya sa table, no? Fragment X has these components D, E, D. Ang fragment Y, DE. Okay? The fragment D and E, no, the final products, yung pinaghiwa-hiwalay na E, D, and D. Sa fibrin naman, iba-iba. May YY, DXD, DED, E, and the D dimer. Yung YY, ay dalawang units of your fragments Y. Ang fragment Y has D and E. Ang DXD naman, ang X contains your DED, right? Ito yon. Kaya siya tinawag na DXD, itong D, X, and D. Dead naman, no? May D-dimer with an E. Fragment is E monomer. The D-dimer, okay, the last, isa sa mga last products which is being used for DIC. So, ayun, that's my last slide. Magpe-prepare ako ng set of questions na gagamitin nyo for self-test lang, no? Hindi yun recorded, pero I highly recommend you to take this self-test para malaman nyo kung paano magtatanong during midterm exam. So, good luck and happy learning!